In the interest of time, I think it's time to get started. We're seeing some more people sign on now. This is great. So again, welcome back everyone to the UofT Grand Rounds. Thank you for joining us this morning. I know it's getting cold and people are back to work, but it's a pleasure to have you here. If there are questions throughout the presentations, please feel free to use a chat function on the right of your screen, and we will try to get the questions to Brian and Mike at an opportune time. And with that said, I'd like to hand it over to Dr. John Lloyd, our program director.
Yes, again, welcome everyone to the second grand rounds of this academic year. This is something that I've been calling Chief Resident Rounds. Chief Resident Rounds is a chance for our residents to showcase what they do and the difficult things they handle on a regular basis. It also gives me the latitude when there are changes in the schedule to call on them at the last minute to help me out. So thank you very, very much, Brian, not only for putting this together, but putting it together on reasonably short notice. So this rounds will be led by our co-chief resident, Dr. Brian McKay, and one of our PGY2 residents will be presenting Mike Caputo. And there may be more, but I don't even know. It's a surprise to me as well. No, okay. All right, so without any further ado, guys, you may take it away.
All right, so can everyone see the screen okay?
Yes.
Okay, great. So today's talk is, like Dr. Lloyd said, is going to be on some challenging things seen on a day-to-day type call basis. That some of the things were worked up later on, but let's see. That's good. All right, so I am Brian, not Byron McKay, raised in Mississauga, from Melbourne, co-chief resident, and just because this is over Zoom and we don't have that personal touch, we're just presenting an interesting fact about Mike and myself. So I'm an ice hockey goaltender. That's me at a Docks on Ice hockey tournament. I'm here today with Mike Caputo. He's a second-year resident in our program, currently at Sunnybrook. He's originally from Sault Ste. Marie, through Northern Ontario Medical School. An interesting fact about him, he's a scratch golfer. As you can see here, he's teeing off in some sort of beautiful location, which is likely pre-COVID. So today, presenting 4 to 5 unique cases. I say 4 to 5 just depending on time, but some unique cases, all with very important differentials. So I'm just going to do a quick background talk about unilateral vision loss. So in Canada, approximately 1 in 8 Canadians over 15 visits an emergency department at least once a year. In the US, which is where I had better numbers with some breakdowns, about 128 million ED visits happened in 2010, and roughly 2 million of those were ophthalmic principal diagnosis. Most common things are common, obviously, but the demographics are interesting. They generally tended to be males, 18 to 44, and from urban locales. And most commonly, things like conjunctivitis, corneal foreign body, corneal injury, eye pain. But of the non-injury related presentations, anywhere from 5 to 15% were for acute unilateral visual disturbances. So why visual disturbances unilaterally? Well, these are often puzzling if they're not clear cut. Like obviously retinal detachments or vein occlusions, artery occlusions, hemorrhages, those are fairly clear cut, but things can be quite subtle sometimes. They can often have long differentials, and we'll go through some key differentials today. And some of these may be very difficult to see, or it may easily dismiss these as something like vitreous syneresis or PVD. And so we're just going to provide you some important differentials to consider. And many of these cases are from cases I've seen on call or over weekends over the last year or two. So without further ado, I'm going to switch screens with Mike here, and it's going to take away from the first case.
Thanks, Brian. So this case is called Just a Little Blurry. And so the initial presentation was a 63-year-old female of African descent, and her chief complaint was blurry vision in the left eye that had been going on for a number of weeks. She didn't have any past ocular history to note, but was a diabetic, not treated with insulin, but with metformin for many years. as well as having hypertension and paroxysmal AFib, which did not require anticoagulation. She hadn't had an episode for a number of years, but she was on ASA 81, metformin, hydrochlorothiazide, and atorvastatin. Her vision was quite good. She was 20/30 without any correction, and the pressures were good. Pupils were equal and reactive without IPD. Anterior segment exam was quite normal. She did have nuclear sclerotic cataracts, 2+ bilaterally. Looking at the posterior segment exam, so the right eye color fundus photo shows completely unremarkable macula disc and the mid periphery that we can see up to. And looking at the left eye, there's these creamy white, the most striking thing is these creamy white yellow lesions that appear, just nasal to the disc, as well as a few dot blot heme, just inferior to that area. So if we just zoom in, it just shows us a little bit more clearly the interesting pattern and shape of those. I mean, they look similar to hard exudates, but there's certainly something different about them and the way that they're located. So does anyone want to volunteer? I know everyone's always dying to volunteer to answer a question at 7:30 in the morning at Grand Rounds. So whoever's most excited, please, shout out an answer. What do you think the next best step would be here for us to best work up this patient?
I want to help you out, Mike. I'm just going to unmute some people. So we've got Shabo here.
I knew I could count on Shabo.
Or Jason. Let's see if either of them are around.
I would get additional imaging to investigate it.
Great answer. Yeah, I agree. And so that's what we did. And if you look here, there's a red-free photograph of the right and left eyes showing reflective lesions, right, mainly around the disc, but nothing around the fovea. And it's only affecting the left eye. The right, again, looks completely normal. And so just now moving to this next slide. So from the top left.
Hey, Mike, go back for a second to the slide.
Yeah.
I thought there was an abnormality in the right eye there. Down along that vein, there's some hemorrhages there.
Yeah, there is. I guess there is a little bit of a hemorrhage there.
Or along the artery there, actually.
I didn't see. Yeah.
Okay. Anyway, just.
Yeah, no, that's a good catch there. But moving on to the next photo here, so we have, from the top left, showing the first two images represent the early mid AV phase, and essentially showing not much. But the photo on the upper right is actually the AV phase and a little nasal to the disc. There's a few punctate lesions and also a patchy area of hyperfluorescence, and just below that is a zoomed in version of that upper right photograph, and it shows a little bit of a fuzzy patch crossing two vessels, and there's also telangiectatic changes noted at the vessels with an aneurysm, and if it's in retrospect, it's a little bit more clear, but it looks almost like a glowing light bulb if you look at it from a certain perspective. And so there's some early perivascular blockage as well. May or may not be some focal areas of capillary dropout. In the bottom left corner of the screen, the red circle didn't seem to make it to the slide, but in the bottom left part of that bottom left image, there's a little area that is most likely capillary dropout. There's a little blackout circle there. So this is showing an FA unremarkable in the right eye without straining or leakage. It's early and late phase there. And here we have OCT of both eyes. The macula showing areas of intraretinal hyperreflectivity in the left eye, which is consistent with the hard exudates that we already seen on fundus photographs. Epiretinally is a little bit of corrugation, but nothing else. So in terms of a differential for retinal exudates, does anyone want to give us maybe even just one thing that we could add to our differential? Shabo?
Well, in this case, given the history of diabetes, the first thing you would consider would be a diabetic retinopathy. And then, but if this is a diabetic retinopathy, you would expect to be seeing like symmetric changes in both eyes. But this case is primarily in the left eye. Then you would consider other comorbidity, such as an old CRVO or BRVO, or sometimes just retina vascular telangiectasia, like idiopathic form. And then, that's some three top differential diagnosis here. And then, but in this case, just a blurry. And then 20/30 vision, cataract can explain 20/30 vision in this case. And then the fovea is pretty much non-involved. So I would probably consider observing this case and just ask the family doctor to optimize the vascular factor.
Yeah, I think that's great. And I think those, hit most of our top 3 or 4, hypertension, diabetes, and, looking at it being a unilateral case.
Differential to also consider is like something like Coates disease as well. I think that falls within, anyways.
Yeah, that's definitely a really good point. And so, in terms of the you can break this up in many different ways, but looking at it in terms of vascular to start with, so diabetes, hypertension, your retinal vein occlusions, and of course, Coates disease is something that maybe not is in the most common top 3 of our differential, but it should probably make it to number 4. And macular aneurysm, ROP, FEVR. And there's an inflammatory infectious, category we need to work through with neuroretinitis, sarcoidosis, lupus, and then of course degenerative as well, including CNV of any etiology. And so this is adult onset Coates disease, and so it's an idiopathic retinal vascular disorder characterized by 5 stages, starting with telangiectasias in stage 1, exits to stage 2, and then at stage 3 you see subtotal and total RD. There's secondary glaucoma for stage 4, I should say, and pre-phthisis for stage 5. And very helpful is that 75% of these cases occur in male, and it's 95% of the time unilateral, which would be very different from something like a systemic disorder such as diabetes, where most often there's bilateral changes, even though they may not be symmetric. There's often at least some background retinopathy. So the exits can often, in these cases of Coates disease, be found in the peripheral retina rather than centered around the macula. There's light bulbs on IVFA, as we mentioned, that look like they're glowing, and telangiectatic vessels, of course. So in terms of the treatment paradigm, the older that the patient is, the better the prognosis and the older the lesions are, and so spontaneous regression is possible. It depends really all on the stage. And so you can do laser photocoagulation as well as cryo. Sometimes intravitreal anti-VEGF injections are given as well as steroids. And surgery can also be undertaken. So the take-home points for this, just wrapping up this first case, is that Coates disease, not a very common thing, but something that you should always keep on your differential for retinal exudates. And it's a disease of anomalous, leaking vessels, secondary telangiectasia, and then B exudates from the leakage, and you can get an exudative retinal detachment. Presentation has a better prognosis, sometimes with actual spontaneous regression without any treatment, and essentially just be suspicious with a lot of hard exudates in the peripheral retina, that it just may not be another case of diabetes or hypertensive retinopathy.
And before you go, Mike, before you go to your next case, question for you and Brian. How did you confirm the diagnosis, just presumably from its clinical appearance? Did you work the patient up for sarcoid, and was in fact it picked up by chance? Because as Shabo pointed out, she didn't have anything in the fovea. So I'm curious as to how she even knew her vision was blurry.
There were a few flecks of intraretinal hyperreflective material, which are likely exudative in the left eye. So I think that might have given her just some mild blur. It was just persistent. She just felt it was not right. She did have hypertension, but it was controlled, and I think that's why you saw the hemorrhage in the other eye. I think so. She did get that optimized, but essentially after the IVFA, the retina specialist involved said that this is very much in keeping clinically and on imaging, on multimodal imaging with onset Coats disease, barring that there was some additional workup. I'm not sure if we actually did ACE and chest X-ray in this case. I can't recall actually, but there was some additional workup that was all negative, so that was the leading differential there.
Great. Any other questions before moving on to case 2? All right, so I kept it original here. It's really creative with the title, just a little blurry again. So just looking at the initial presentation of this patient, so it was again a complaint of blurry vision for a few days in the right eye, no significant past ocular history. This patient is a 14-year-old female at Sick Kids Hospital with ALL and has had 2 allogenic bone marrow transplants for relapses. In terms of medications, she's taking the ITP, ATG conditioning regimen for the second BMT, and methotrexate for graft versus host prophylaxis. And in terms of what's your working diagnosis, it could be anything at this point, especially in the setting of a pediatric ALL immunosuppressed patient. But most importantly and urgently, it's to rule out infectious etiologies and infiltrative compressive disease. So on exam, she appeared well, but quite pale, a little bit cachectic, but non-toxic, and was alert and oriented. But the vision was actually 20/20 bilaterally. Interestingly enough, even with the complaint of blurry vision, pressures were unremarkable. Her pupil exam was normal, and slit lamp exam was also normal. In terms of DFE, moving to the next slide here, so see a color fundus photo montage of the right eye, and it's completely normal. There's nothing really to note there. Oops. And now looking at the OCT of both the right and left eye, and the macula, it's completely, at least in terms of my view, completely normal. And so what's missing here? So there's faint hyperreflective flex nasal in the vitreous in the right eye on OCT. Is an artifact. And so we see here that there's these spirotemporal retinal, it's like a white ring, which doesn't look great. And so the most important thing is to do the peripheral exam. And after the peripheral exam, of course, it's to open Epic and review the patient's chart and look at last bloods. And so here there was a CMV positive blood culture, and it seemed like this was probably our cause of that lesion, with it being in keeping with what those lesions look like. And so based on the bloods, oral Belga cyclovir was started. Case was discussed with the team. ID and oncology were involved, and everyone agreed to treat. So the initial follow-up showed that there was no further progression, which seemed okay, but no regression. And so in terms of a differential for white retinal lesions, we made you guys, volunteer last time, but it's a huge list. There's, from TB to sarcoid, syphilis, retinitis, of course, endogenous endophthalmitis, Lyme, toxo, both toxoplasmosis and toxocara, VKH, chorioretinal metastatic disease, leukemic retinopathy, and melanolytic choroidal melanoma. So this is an Optos color photo showing the right
Sorry,
eye.
Mike,
Yes.
before you go on, just can you clarify one thing?
Yes.
You mentioned bloods. You made it sound like she'd already had bloods taken even before the eye, like she had CMV tested for some other reason, or was tested because of the eye problem?
I think I was just getting at, you know, reviewing to see if there was anything in there, but we did order the blood cultures. Like ID, I think, had ordered them actually.
Yeah, to clarify, that was she had some diarrhea, and because of her immunocompromised state, they'd ordered
stuff.
Yeah.
Thanks, Brian. And so, yeah, so just moving on. So you can see in this color fundus photo, color ontos photo, I should say, that of the right eye, that there's more lesions in the retina compared to the previous one that we just saw. There's a new area of temporal whitening as well. And so you can see progression here, very clearly represented by these two color fundus photos. So at presentation, there was much less in the way of these lesions. After 2 weeks of treatment for CMV, there's been worsening. So what to do? So I learned through this case that about 10% of cases of CMV are resistant to valganciclovir, or actually I think ganciclovir. I think I'm getting a little bit ahead of myself. So the intravitreal ganciclovir was started for the right eye. AC paracentesis was obtained at this time rather than at the beginning, as well as toxoplasmosis. 2 weeks later, see the vision listed at the bottom there that it's worsened. And so because CMV, about 10% of cases are resistant to ganciclovir, foscarnet can be added to an intravitreal injection in order to help improve its effectiveness. So the AC tap was done with viral PCR and toxoplasmosis, and all of a sudden this is a toxoplasma case. So looking at the life cycle, going way back to parasitology, we didn't learn much of this in med school, but I took it as an undergrad. It's a definitive host of toxo, our cats, and so it gets, unsporulated cysts get passed through the fecal cycle. Sometimes there's another host with the mice who eat it from the feces, and anyhow, long story short, this is the life cycle. So humans can become infected from a lot of different ways, depending on which part of the world you are living in. Each one may be weighted a certain way. And so consuming food or contaminated, cat feces, blood transfusion, as well as transplant it can occur. So classic findings with Toxolon exam are headlight in the fog. And so I have a great example on the next slide, just showing a white focal retinitis with overlying inflammation. It makes it look just the way a headlight in a fog does. And so if we go here, you can see that appearance, very characteristic. So getting back to the case, she was treated systemically with oral prednisone, pulse with taper, as well as sulfadiazine, 1500 daily. Because of this immunosuppression she already had, primethamine wasn't used. The IV ganciclovir was discontinued. She also received Clinda, and there was a good response. As you can see, the vision began to normalize with decrease in her subjective vision changes. 6 months later, you can see that the lesions are stabilized. And I think I'm going over time for Brian. He has 4 cases to get through here, but just close on 20 minutes. So I'm just going to wrap this up here. So classic therapy for toxoplasmosis includes primethamine, which we didn't use in this case, but you usually add that to sulfadiazine. Pediatric doses are listed there, but unless you're in pediatrics or providing care to pediatrics, we'll just skip that for now. So treatment considerations, if there's a lesion threatening the optic nerve or fovea, anything with moderate to severe vitritis, anything greater than or equal to 1 disc diameter in size, multiple active lesions in those who are immunocompromised, such as in our patient or pregnant, are reasons to treat. And when to AC tap it seems like pretty much always, and to do it early. if there's a high suspicion, you should have a high suspicion, especially in immunocompetent patients. And that's heading on 22 minutes here, Brian, so I don't want to cut into your time anymore. Does anyone have any questions about this second case?
So did you do the AC tap, Brian?
No, it was actually done by Carolina Franciscone, who's the former Mooney's former fellow. She in clinic at Sick Kids.
How much fluid do you have to take to test for all those things?
Got about two microliters out of the, or 0.2 cc out of the anterior chamber. You need at least 0.2 cc for the CMV PCR. I know I've sent off ones that were not quite that big and ended up not getting reported. And the microbiologist would call saying, we need more sample. So it's kind of tough. I do kind of call them ahead of time to let them know that we're trying to do like a complete viral PCR plus or minus toxo. And, you know, we say it's precious and we hope that, you know, they were able to use it. Sometimes they'll keep it and you can augment it the next day with a little bit more fluid, which we have done too. At the Western have done that, but Sick Kids are pretty good, so they were able to get it through. So with this case, I think it was interesting because the diagnostic momentum leading into them being seen in clinic was actually CMV, and then the white lesion is like, oh, this is CMV. So initially an AC tap wasn't done; it was just treated on spec. But then obviously it was not responding to treatment. So there was a kind of a delay where I thought, oh, maybe it was resistant. Let's add foscarnet. But a secondary, you know, AC tap hadn't really been done. It had been discussed, but it just never actually was done until he was still not responding to foscarnet either, and it was still getting worse, and there's little lesions starting to appear in both eyes. That's when the AC tap was redone, and within a day or two, we came back with toxo, and we just changed everything. The whole treatment plan changed. She responded very well and made a very good recovery from that.
That's an interesting case, Brian. And there wasn't a lot of vitritis, right, in the case?
No, it was hard to see on the optos, but it's focal vitritis kind of overlying that white area. But there was very little vitritis. Good on her for picking up that it was blurry, because I think the only reason she had that eye being a little bit blurry was because there was some mild vitritis, and she's just she's a very smart, very aware child, so it's probably saved her eye.
Like this would be like the port variant of toxoplasmosis.
Yeah, it looks similar to that, yeah. Okay, so I'm gonna, I think my screen is being shared now.
Thanks, Brian.
Yeah.
Just regarding the Emirates point, you have to, in immunity, you should not expect like much of vitritis or anterior chamber inflammation. Right. So they don't develop inflammation against the virus. So in immunocompromised patients, you know, you always should have like high suspicion. You know, similar, like it's not like in ideal situations that in toxo you will see significant vitritis with AC inflammation and pain. These patients could be like totally painless, no much of inflammation, and things could overlap. Like for you clinically, you think this is more of like CMV, turns up to be toxo. A good case. Thank you.
That's a very good point. That's a very good point. So moving on, switching gears a little bit, this is the case of the central smudge here. So this is another pediatric case, actually. This is a 12-year-old girl who presented at St. Mike's Retina Service from a referral from a general ophthalmologist for a central smudge in her eye. So she was seen by the general ophthalmologist on call because her parent was concerned because for a week she'd been noticing this kind of brown smudge in her central vision. It hadn't really told her parents, but since it didn't go away after a few days, she got worried, told her mom, and her mom brought her in to emerge. She saw a general ophthalmologist who saw that something wasn't quite right with the right eye and sent her down to St. Mike's. So we saw her the next day. And Past ocular history was very unremarkable. She had had a normal ophthalmic exam, optometric exam 6 months prior. Past medical history was unremarkable. Some mild asthma. She used a salbutamol puffer for, and she had a potential allergy to cephalosporins and penicillin, but it's not confirmed. So I'll just go through her presentation timeline a little bit. So January 23rd, she reported having a severe headache and then noticing over that day that she was developing a dark spot in the right eye. So about a week went by before she was seen by that general ophthalmologist and then on to us for this opinion about the scotoma. On exam again, this is an ongoing theme here. The patient was 20/20 in both eyes. IOP was normal, slit lamp was unremarkable, and the fundus on quick glance was unremarkable. So this is the Optos wide field imaging of both eyes. And I mean, the most striking thing you can see here is that there's some vessel tortuosity, but otherwise, on a quick glance, everything looks relatively normal. So repeating the field, you can see that she does have a central scotoma, just slightly superior to the horizontal meridian, in which that's exactly where she describes it in her general vision. So when we zoom in a little bit here, you can really see there are some quite tortuous vessels in the right eye here. And if you look at the fovea, I think you can probably see that. Let's turn on the laser. Fovea here, a good macular mound with a good light reflex. And here there is still light reflex, but you can see this distortion, the nice shine to the ILM. It's a little distorted here compared to the other eye. And you have to take my word for it because this color photo is false color. So this area here is slightly pale and slightly elevated on clinical exam. So we took over the OCT. This is the swept source on-phos infrared image. And you can see in that area I was outlining, there is this kind of graying, globular graying of the on-phos image. And when we look at the actual OCT, I'll just make it sequentially more zoomed in here. You can see this internuclear layer has this hyperreflectivity to it. It's very like abrupt, hyperreflective band here in the internuclear layer. So looking at just to further this, looking at that on-phos again, but the elevation map, you can see it's focally elevated there, and it corresponds to this area around this inferior ciliary retinal artery. So we already did a bit of a differential for retinal wiping. So of course the infective stuff that Mike discussed here, and inflammatory, BK sarcoid, infiltrative, you always have to think about these infiltrative things, but also, trauma, commotio, Terra, loboma even, and acquired things like staphylomas and atrophy are all underlying your existence of white retinal lesions. So we did some further history because the child was well. And so we did some further history here. And on January 22nd, which is about 24 hours before waking up with a severe headache, she received a menactra vaccine, a meningococcal vaccine, as part of her normal childhood vaccination scheduling. So that was the only other positive thing to note on her history. There was no history of anything else, and she was generally well and has seen her family doctor regularly. So when we looked at the OCTA and the swept source through this area of swelling, you could see that there was some attenuation of flow in the deep capillary plexus in that area. And the area that in question that we were seeing was related to this ciliary retinal artery. And so we're like, well, why would there be flow restriction just there, and what's going on with this tortuosity? So looked at it further, it's actually a little bit more than you think. So it's very subtle, but there are hemorrhages in all four quadrants and a few flame hemorrhages here and there, and a little bit of fuzzing of the margin here. So this actually is more in keeping with central retinal vein occlusion. So that's where we're thinking moving forward into here. So she came back a week later. We basically sent her for a complete workup to rule out infectious and and systemic causes that would cause focal retinal whitening. Again, she comes back, 20/20 vision, nothing's really changed. Her family doctor said the workup was negative, she's completely healthy, and so her CBC, ESR, CRP, electrolytes, urinalysis, ANA, anti-double-stranded DNA, HbA1c, syphilis, Lyme, Bartonella, serology, all came normal. Yeah.
Did you do any hemophilia? No, thrombophilia workup?
We did like protein CNS and anticardiolipin antibody as well.
Yeah, it's a very weird presentation. It seems that she has combined ERAO or some degree of arterial occlusion and CRVO. So it's a very peculiar appearance of the fundus.
Agree.
So you can actually get, commonly not commonly, and you can actually get a combined cilioretinal artery occlusion with a CRVO, and they postulate it's due to like some hemodynamic block due to low perfusion pressure of the choroid, which supplies the cilioretinal artery. But I wonder whether this is more. Anyways, the diagnosis is on.
Jason has read my slide before. So yes, this is so we decided that this is something called paracentral middle acute middle maculopathy, or PAM, and etiology of this one is likely from this non-ischemic CRVO with a secondary ciliary retinal artery occlusion, or not so much a traditional occlusion, but most likely a poor perfusion with decreased flow in the deep capillary plexus observed following vaccination. So the plan at this stage is to observe, because there wasn't much to do there. So a little bit on PAM itself.
Don't pass this case out to the anti-vaxxers, Brian.
I know, I'll get to that in a second. So this is first reported by Dave Seraf as a variant to acute macular neuroretinopathy based on OCT findings. So this is an OCT diagnosis, PAM is. Clinical findings of these gray lesions and with a near-infrared reflectance like we saw on the ONFOS, with hyperreflective band, which can be multiple, or focal, or isolated, or these even diffuse at the level of the internuclear layer. And these patients all present with an acute onset paracentral or central scotoma. It's really, I say unknown etiology, but it's actually variable. There's a lot of different conditions it's been reported in. You always have to rule out infectious, inflammatory, and, as Chabot said, issues with blood flow and hypercoagulability. Treatment is just observation, and the prognosis is actually really good. Partial to full resolution is common. Some may still have scotoma on Humphrey visual field, but young patients like this, which she's only 12 here, neuroplasticity is very good. So even with a small scotoma, they're able to kind of develop, so they can't really notice it very often. So the differential for PAM really is idiopathic, so some cases have no known cause. A lot of them are secondary though, like Jason said, combined CRVO, CRAOs, diabetic retinopathy, hypertensive retinopathy, and other types of retinopathy. Anything that's going to decrease perfusion to the retina can cause this. It's also been shown in case reports for migraines, multiple medications, hypovolemia, orbital compression injury, but also viral prodrome. And interestingly enough, there's one report of a post-H1N1 vaccination. And as Jason did point out here, cilioretinal artery hyperperfusion can be a thing where it's actually just low perfusion pressure or occlusion of it, partial occlusion of it from other arterial or vasospasm in that tight area coming through into the eye, leading to changes in perfusion, which in this area is kind of a watershed area between the different layers. And just enough, once you drop the perfusion just low enough in this area, you can actually infarct the internuclear layer. And you can see here, they noted this in 51 different eyes in their case series here. And this is a paper from Dave Seraf. There's a lot of different case reports on this. The only one I could really find was with this H1N1 vaccine, a 53-year-old lady. So we're trying to figure out, are there reports of vaccinations, especially this vaccination, ever causing this? Because we had no other reason for for this, and the timing was very suspicious. So we saw that influenza vaccination has also done this. The H1N1 vaccination has done it. But interestingly, the meningococcal vaccine has done some other things to the eye. A patient in Australia had this multifocal placoid epitheliopathy of the pigment epithelial cells, and that was post-meningococcal C vaccine, so it's a different vaccine. It's also Amadip and Dr. Mandelkorn had published this a few years back, where there was just a pan-uveitis orbital inflammation secondary to influenza vaccination. So vaccines, although these are extremely rare, vaccines can cause some weird and wonderful things for reasons which still escape us. So back to this case, 6 months later, she had a mild resolution. She still notices it sometimes, but the size of her little smudges almost diminished completely. She's 20/20 with no REPD. The swep source did note significant internuclear thinning atrophy with attenuation of the outer plexiform layer. ONFOS actually demonstrates quite nicely the vascular tortuosity is gone, which I'll show you in a moment. And the OCTA revealed that the normal flow is in the larger capillaries and arterioles, but this superficial capillary plexus had some alterations. Or sorry, in the deep capillary plexus, some alterations. So this is the ONFOS at presentation, infrared ONFOS. And you can see this vascular tortuosity. And this is 6 months later, almost completely normal, just a little bit of a shine here. And when we look 6 months later, there's this focal atrophy noted, which I'll show you quite nicely in this photo. I really like this photo. It hits home just what she's left with, this large area of atrophy. And if you actually look at this segmentation of the deep capillary plexus on OCTA, the swep source, you can see that there is just that area corresponds to decreased flow, likely from the infarction. So a conclusion here, it seems like she had a vaccination-induced vascular reaction, possibly vasospasm, that produced migraine and also some flow restrictions in the right eye for whatever reason. It's still unclear. And this resulted in deep capillary networks having decreased flow and infarcting just a small segment of her eye. Other etiology were all ruled out, so the most likely reaction is probably from vaccination. This is the first reported case with a meningococcal vaccine, and it's the youngest case of PAM I could find in the literature. So that begs the question, do you report these things? Right now, especially, we're in an age of anti-vaccination, as Dr. Webb is saying, and it's a little troubling to try to give more fuel to the fire. However, this is such a rare occurrence, but we felt, it was prudent that we should share it at least among ophthalmologists. So we sent this out, and it was recently picked up at the CJO. So we thought it was prudent to report it, just because the more we know about these things, the better. But again, it was a long talk between Dr. Takim and Dr. Wong and I, and in the end, we decided that we should go forth and actually publish it. So let's see how we're doing for time. Okay, we're doing okay. So this, the next case, actually, does anyone have any questions about PAM or that particular case?
Brian, what I find fascinating about PAM is just how new this diagnosis is. I remember when I was a resident, it was just coming out, and it's really fascinating how much OCT is changing our specialty, because that's a diagnosis that's probably like 6 or 7 years old at this point. Many young people have graduated and the diagnosis came after their residency was completed. So it's fascinating how fast this area is evolving.
Yeah, I agree. And I think this is actually the second case of PAM I've seen on call. The first one I didn't really know what it was. I was PGY2 at Sunnybrook, and a young guy came in and he had that. I didn't really notice it until I was with Jason Noble in clinic, and I asked him, because I was like, I had this weird case, and he's like, looked at the OCT, he's like, oh, it's PAM. So again, I'll just put up the OCT for a second, just for those who haven't seen this clinically yet. It's this very focal internuclear layer hyperreflectivity band, and usually if you look at the ONFOS, there's a nice corresponding area right there. So that, and this is the backed out. So that when you see that, and the patient has a paracentral scotoma, it's very, very highly suspicious for PAM.
Hi, Brian. I just wanted to make one comment.
Yeah.
That was a great case, and yours was yours. You kind of knew there was something going on because you could see the signs of the CRVO. But
Yes.
sometimes with PAM and also with acute macular neuroretinopathy, which affects the outer retina more, the fundus will look essentially normal on exam. And basically the only way to diagnose this is with OCT. And I think it's a good trend. I'm noticing that on the weekends and evenings, residents have access to OCT. And it's not a technically challenging test to perform, but sometimes the problem is these patients come in dilated from the optometrist with significantly central blurred vision, and you might think it's optic neuritis or an optic neuropathy, and these patients sometimes end up with neurology admitted for a while. When if you had access to an OCT, you could clinch the diagnosis and then get these patients into the retina clinic during the week. So I think knowing how to use the OCT and having access to it does help on call and on evenings and weekends.
That's a very good point. If we can get to my last case, I do show that because I actually was something that, because I had that access to imaging, it helped me with the puzzling diagnosis. So thanks for that. That was a very good point. So I'm going to try to get through this case quickly. I think this is a very interesting case because it's, again, very subtle. So these are all a theme of subtlety, I guess. So this is another young male, 15-year-old man, or 15-year-old boy, I guess, and he had a left visual disturbance. So he describes after some talking that he's had for about a year almost now, this white dot in the center of his vision that he just said was annoying. So he didn't tell his parents about it until quite late, which is an ongoing theme here as well. But he describes about a quarter-sized at arm's length noticeable spot, white spot. He describes this as like a tiny veiny structure when he looks at the eye chart, but he can see well. We asked him about color vision, and he said he was not really sure. Maybe they're more blended. I wasn't even really sure what he meant by that. I don't think he was either. He denied any night vision issues or problems with peripheral vision. Past medical history was unremarkable, except for he had some ADHD. Family medical history, there's no known retinal disease or blindness. His mother did have a history of JRA. On exam, he's 20/30, 20/25. So actually a little bit better vision in his left eye, which is his eye with the problem. Refraction was pretty much normal. Exam was pretty much normal. Ishihara, though, he did that. Yeah, so he had no APD, and Ishihara was completely normal. Genomes are full, and anterior segment is completely normal. Looking at the posterior segment, so this, sorry about the lid artifact, but I'll zoom in here just to make it a little easier. There's nothing in the periphery. There's no bone speculations or anything like that. So when we zoom in a bit, I don't know, the screen is flying all over the place. Zoom in a bit, disc vessel macula all look within normal. Fovea looks normal. There's no real changes in the, no modeling of the RPE or anything that would be concerning. Appears to have a normal foveal light reflex. So this patient came to clinic and we did some of this imaging after the scene, but you can see here that on the imaging that there really is nothing on the autofluorescence. It's completely normal. So question would be like, what would we do next? Obviously, because we're in clinic now, let's go to the OCT. So OCT, you're looking at this, I mean, all the layers look fairly normal. There may be some hyperreflectivity in that fovea, but is that artifact or is it something? Does that explain a paracentral scotoma? Not sure. So the next thing to do is obviously just confirm that the patient actually has some scotoma or that we can measure one. In this case, he got a gold one. This is the left eye. This is the right eye. So left eye, right eye's normal. There's some area here where he might have been blinking, but the left eye definitely shows that he has some sort of vision loss there. So you're scratching your head, what's going on here? There's something, everything looks normal. And then you check the ONFOS again. So ONFOS, a lot of people don't use this, but that's a very good tool for screening because it uses near infrared. So it's a different view than you get with color photos and the OCT itself. So when you're looking at that, you're like, oh, spots here. So what is going on there? So let's go back to the cube and actually scroll through it. Going up from the bottom, right eye is here, left eye is on the corresponding side. Going up, everything looks normal until you get to the little spot here, this little gap. And same with this side, there's this little gap, maybe some hyperreflective material there. Can that explain the vision? So what is a small optical gap? Well, before we go and talk to this kid more, we need to know the differential of an outer retinal OCT optical gap, optical empty lesion. So common things, laser-associated injury, solar maculopathy, tamoxifen maculopathy can do this. Alkyl nitrate, Popper's maculopathy. This is a recreational drug that has been shown to cause it. Also, broad monochromatism or achromatopsia, cone dystrophies, macular dystrophy, Stargardt. So that's why I was talking. We did check the FAF and looked at his color vision, because with kids especially too, you want to make sure you're catching any of these congenital or inherited retinal dystrophies early. So what other questions would I want to ask him? So we walked back in the room, and of course, medication history. Only took Concerta, that was discontinued, that was for his ADHD. He says he's never been sun gazing. He doesn't even know what poppers are, and he denies any recreational drug use. He endorses one episode of seeing flash from a welding torch, but said it didn't really cause any problems, and he didn't have any issue after that he knows of. So when we ask him about lasers, he immediately promises that he doesn't stare into his class 3B laser pointer that he owns. And during this discussion, he's kind of regaling us with this description of how amazing it is and its brilliance. And he knows a lot about lasers. And he knows how to disassemble them and reassemble them. But of course, he says he doesn't stare at them. And my thought is, sure, okay. So lasers. So this is actually really important. I don't think we go over this too often in rounds, but class 3B lasers are extremely unsafe, even for momentary viewing. So what is a class 3B laser? Well, if you look at it's based on power. And if you look at a class 3B, we're talking about powers we use for photocoagulation. So
yeah, good. How are you?
So
this child has a class 3B laser, which is into the, his is, I think was about
usually triage it unless it's
250 milliwatts. So this is enough to photocoagulate. So where do you get these lasers? Well, they're not available in stores because they're restricted. So, but you can buy them on the internet, which is what he was doing. And I feel we've seen many reports of injuries from athletes, pilots even. There's case reports of pilots with paracentric scotoma from being hit with lasers by people shining lights at airplanes. So this is extremely dangerous, and these things are very powerful. So I think, with quarantine, people getting bored, I've noticed even in my neighborhood, people shining lasers on some of the buildings. So this is something we may see more of, especially as, people are getting bored, they're at home, they're on the internet too much, and we may be seeing a little bit more of this. So laser-associated maculopathy is really synonymous with photic or solar maculopathy. It's all about the same thing. It's light-induced injury. Symptoms can include very blurry vision, paracentric scotoma. It can be unilateral. More commonly, it's bilateral. In this presentation, it's asymmetric. They can have some dyschromatopsias and metamorphopsias with that. It's an acute presentation. They often have some pain associated with that. Vision in most of the reports tends to vary from 20/20 to pretty bad, depending on how much of the fovea has been burned. And fundus findings may be very subtle, like in this case, or they may have this classic yellow spot with a halo of pigmentary change, or sometimes without any pigmentary changes, depending on the timing. OCT generally shows a small optical gap. Sometimes a small lamellar hole or foveal depression can be seen as well, and this usually happens in a couple weeks post-exposure. Prognosis is usually fairly okay. They usually retain or recover most of their vision in the first 6 months of exposure if they haven't had any re-exposures. But the scotoma and sometimes metamorphopsia, those things can tend to exist because they've done full thickness damage usually. So the treatment here is to discontinue laser gazing. Observation is what we do, and acquired optical gap can also phenocopy inherited retinal diseases. So if there's an atypical workup or the history seems a little off, it's prudent to continue going through and discussing further testing. And in this case, actually, this case was further worked up by Brian Balios, of course. So, of course, he wanted to make sure that this patient didn't have any inherited retinal dystrophy. So they got a full Farnsworth and they got an ERG, which was all normal. And I think we're probably going to wrap up. Probably don't have time to go through this case. It's a very interesting case.
Brian, what was that goaltender? That was a fan in the audience shining a laser at the...
Yes.
Yeah? Did that goaltender get injured by it?
No, but there are a lot of reports actually out of Europe showing soccer players specifically getting hit with lasers during their at some point in the game, and then they end up with scotoma from it. Yeah.
So even at that distance, it can still, like, it's...
Depends on the laser. So some classes of lasers have to be quite close, but class 4 laser, which if you put the power up over 500 on an argon laser, it says that even the scatter of the light can be damaging, which is why if you have someone in the room with you and you're doing the photocoagulation, even though they're only seeing scattered light, they're supposed to still wear the filtered glasses, because at that power, even just the light scatter can do it. And these handheld lasers are extremely powerful. It's quite amazing.
Wow. And you mentioned that you don't just buy them at Staples, but what are they supposed to be used for? Class 3 and 4.
The thing is, like, so the laser, I'm not entirely sure what they're marketed at. I think they're military grade lasers basically, and in Ryan's retina, they talk about anything over, like, I think 250 is technically not a laser anymore. It's a photocoagulator. It's still a laser by physics terms, but by practicality terms, it's like a photocoagulator. So it has the ability for quite destructive power. And I think they're just marketed as military grade. So, like, it seems cool. Like, hey, look at how bright my laser is. It's almost a lightsaber. That's why. And
do you think this child who swears he doesn't look into it, could a reflection from something?
Based on those spots, there's so many of them, and they're all kind of like very small. It's likely that when he's putting them together, because he had quite a powerful laser, that he's just getting reflected beam, and it's just hitting him, but he's not really noticing it. But after he's acquired like 10 shots in there, he's getting this veiny. I think that's why he had a veiny scotoma too, because it's actually little tiny scotomas kind of lining up. I think that's what he's getting.
You know what? That's a very interesting and very cautionary tale, especially for those of us who have kids who are going to be ordering stuff on the internet.
Yeah, just that these things are not benign, especially if their powers are over 5 milliwatts. They can actually, at 5 milliwatts, it says don't gaze directly into the laser, but anything above that can cause immediate damage. So that's a very good cautionary tale.
Well, I just want to thank both of you for great rounds. I really do think the chief resident rounds are sometimes some of the most fabulous rounds, and they really do get back to clinically interesting cases that are relevant to us all. And so thank you both very, very much for putting that together. This is our more typical rounds format. We try to make it clinically relevant, present interesting cases of that show new knowledge or involve things that are relevant to all of us in ophthalmology that we may see. So next week we look forward to welcoming back Dr. Crystal Chung. She's one of our graduated residents from a couple of years ago. She's returning with some fabulous knowledge from Boston, and we look forward to her presentation. Do you have any additional closing comments, Amandeep?
Just one quick reminder. So I put a link in the chat box for everyone to submit an evaluation. For the faculty in the audience, that is required for your credits. So please do just take a moment to quickly do that. And again, thank you to Mike and Brian for excellent rounds, very fascinating cases, and we'll see you guys next week.
Okay, thanks everybody. Take care.